Oh, yeah. Good afternoon. Welcome to the HSE press briefing. First, can I ask the speakers to introduce themselves from the left?
Damien McCallion, HSE National Lead for Vaccination and Testing and Tracing.
Colin Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer.
And Paul Reid, CEO.
And I'm Mark Brennock, the National Director of Communications. I'm sorry we don't have any Irish Sign Language interpreters with us this week. There will be a signed version of this press briefing, a recording of it on the HSE Live Twitter feed by tomorrow evening. And first, could I ask Paul Reid to give us an update?
Good afternoon, everybody, and thank you, Mark, again. It won't come as any surprise to all of you to hear me say that the situation in our hospitals and our healthcare system overall is generally very serious. The current wave is putting an inconceivable strain on the health system across all levels of the care that we provide. I think the message has been given and heard very clearly by everybody this week, and the government has responded with a number of public health measures that you all have seen and reported on this week. However, my opening comments today are directed particularly at all healthcare staff, but in particular to our frontline staff, the HSE, and indeed from across all the provisions of services. Any organisation that would have had to deal with any one of the waves throughout COVID that we've had to deal with would be extremely challenged. But to have had to deal with 4 of those waves, along with and on top of a cyber attack, many organisations just wouldn't have survived through all of that. But our health service is a people-driven service, and today I want to pay a particular heartfelt thanks to those people in the HSE and all of our service providers and provisions of health service, who I know at this stage are purely exhausted, frustrated, and indeed at their wits' end with all of this. Your combined resolve, commitment and passion for patient care isn't taken for granted. I wish that this was different, but we all know the reality, and we are forever appreciative and grateful for what you do every day. And as you've also seen, the continued growth in the virus overall of recent times, increasing trend in the number of new cases, which meets the threshold of what's clearly rapid growth. Incidence is rising, including the 7-day incidence rate now greater than 50% of the 14-day rate in 20 of the 26 counties. Just on the current pressures on the health service, this is certainly the highest level of impact and risk that we've had to manage since COVID landed here. I know there's often comparisons made to the numbers of hospitalisations that we had in January through March of over 2,000 and over 200 in ICU. But again, I make the point, at this stage we are dealing with and trying to deal with all other services, and certainly in January the whole of society was in a full lockdown. And just an interesting comparison, back then in January when we did have those 200 patients in ICU with COVID, it was about 10% of the total hospitalisations, whereas now we're running at about 19% of the total hospitalisations being in patients being in ICU. A very severe different impact, drawing on very severe tighter resource. So while there is much discussion and indeed value to be added by other layers that will protect us, such as antigen testing and indeed the booster programme. Our clinical teams are very clear to me that these are not magic wands. These will not solve the situation instantly at a wave. And as much as we'd all hoped they would, we all know our health service will be under unyielding and unrelenting strain over the next while. So today I wanted to set out to you a range of actions that we are taking to mitigate these risks to the greatest extent that we possibly can. We're not here today to just describe the situation, we're also setting out a range of actions that we're taking to mitigate it to the greatest possible extent we can. And there's 5 areas I will bring you through. Firstly, what we're doing in our acutes and community services. Secondly, issues related to our winter plan. Thirdly, what we are doing in terms of the massive demand on our testing and tracing capacity. Fourthly, on the booster vaccines, indeed my colleague Damien McCallion will give some further detail. And finally, fifthly, the key requirement and key ask in terms of public health measures. So firstly, in terms of the acute and community actions, earlier on before this morning, I wrote out a letter to all of our services setting out a range of actions that we will take in support and with them to support our acute and community actions. We know that our big Model 4 hospitals are those under particular and consistent strain in the numbers that they are dealing with. And a primary focus of COVID care and time-sensitive care is what we will have to keep focused on. And this may lead and will lead indeed to some curtailment of elective care. And we will keep a very dedicated focus in this way with these larger Model 4 hospitals over the next 14-day period. Secondly, each hospital will identify surge intensive care beds supported by the redeployment of staff from other activities that we will have to curtail. And we'll continue this focus over the next 7 days working with hospitals to see what they can identify and we will fund. Thirdly, we'll maximise the use of private hospital capacity, and I said out to you before that we have been using up to about 1,100 bed days per week with private hospital capacity. And following further dialogue, we expect to increase that up to about 2,800, probably 3,000 bed days per week to utilise that capacity in the coming weeks as part of our safety net agreement. We'll be mobilising all of our community available capacity to support an acceleration of delayed transfers of care from hospitals. We'll be focusing on a range of hospital avoidance measures, which you will know from home care to other therapies and community-based activities. I've asked for an assessment by our HR teams at a national level to see what further supports we can provide to our staff to dealing with very real issues of fatigue and burnout. We're also appealing again to people, the public, not to attend emergency departments unless there is a real emergency need which cannot be dealt with by a GP, a pharmacy, or reference to other primary care services that we have. This is a message we're always very careful about delivering. If you are concerned that you do need emergency care, we are there for you. You should not hesitate to come forward for that care and you will be looked after. But do consider carefully before you come whether or not it's a genuine, necessary urgency care you need. Second area of actions we're taking relate to our winter plan for 2021-22, and again my colleague Anna Connor will give you some further details on this, but in simple terms, a range of pathways to support us addressing chronic illnesses outside of the hospital. Further funding for GPs for access to diagnostics and other supports to help them and out of hours. Community intervention teams, multidisciplinary teams working in the community, avoiding hospital attendance. Enhanced use of the private hospital capacity, as I just outlined there. Extra bed capacity, both in our acute and community step-down beds also. Expansion of the National Ambulance Service, Pathfinder service. So a range of actions in our winter plan. Thirdly, a number of actions related to capacity in our testing and tracing. And if you just look at the last 7 days, we've tested almost 200,000 lab tests. That's a phenomenal figure that we are now looking at of our total lab tests. And over about 180,000 community referrals over the past 7 days. What we are doing is extending the sites and extending the numbers of sites and the hours of operation of the sites. Further supports we've received from the Defence Forces. Increased use, and we've now concluded engagements and supports from private swabbing operators across the 3 airports. Continued use of antigen tests for public health directed testing and tracing methodology for vaccinated asymptomatic close contacts. Further pop-ups that we're putting in place around the country. Much automation that we've put in place to help people put forward their close contacts. And indeed, we still have the potential to use some offshore lab capacity. However, I will say, in putting all of those extra measures in place, our testing and tracing is under continued strain, and people need to understand and work with us. The level that we are testing right now is beyond anybody's expectations. And we will continue to meet what we can, and people should, if they are symptomatic, should stay at home awaiting a test. On the booster vaccines, very briefly, we'll come to further detail on this later, but just to set out what we are doing in terms of rollout of vaccine, of boosters. We are, unlike some other organisations or health administrations, we did keep in place our vaccination centres infrastructure. We continue to get great support from our GPs as part of the rollout of boosters. We'll be further expanding the capacity of our vaccination centres over the coming weeks. You will be familiar, as NIAC were making their assessments and recommendations, we had to wait a number of weeks. We did lose a lot of staff, and we now have a healthcare system which is severely under strain and needing all the resources it can get. We have a testing and tracing system needing all the resources it can get, and we are mobilising up as well a vaccination workforce for boosters. We're also bringing the pharmacy sector in, which will strengthen our capacity over the next short while, giving us capacity of about up to 30,000 per week. And capacity is being created across all channels to offer an optimum number of appointments to complete each group as quickly as possible. Finally is the 5th measure, which is set out to you in terms of the 5 areas we're putting some actions in. And it is to repeat that all of the above actions are to alleviate or mitigate some of the risks that are on our health system overall. But we do know the most tried, and they are all what we would call 2nd and 3rd lines of defence. We do know that the first line of defence, a tried and trusted measure of our first line of defence, is certainly the public health measures that we can all implement. Strengthening how we all embrace these measures, the individual risk assessments that we all have to make on any given day, but particularly as we look into the next few weeks, trying to reduce the impact on the hospital system into December. Also a call again to business and enterprise to really put in place strong and stringent measures as per the public health guidelines to keep people safe. The working from home, unless in exceptional circumstances as set out. And really key, if you are symptomatic, stay at home, seek a consultation, seek a PCR test. And there's no doubt the benefits of every one of us individually and every household embracing this now over the next few weeks will be really key to protect the health system. And just to give you some summary information of where we are at today, 643 people now in hospital, which is up 20% on last week, and indeed up 40% in the past 2 weeks. Over the past 7 days, 306 admissions of positive COVID patients to hospital. In our ICU right now, this lunchtime, 118 patients in ICU, up 34% on this day last week, and indeed up 38% on 2 weeks ago. Just to give you a flavour of some of the information on our ICU, if I can, ICU admissions between the 27th of June and the 13th of November, 476 ICU admissions in that period of COVID-19 positive patients, of which just over 20% remain in ICU, just over 54% have been discharged, and over 25% sadly passed away in ICU. And again, just on those 476 ICU admissions, 61% of those ICU admissions in that period have either had no vaccine or partial vaccine. It's a really strong, profound figure. And the vaccination status today in hospital, fully vaccinated of all the COVID positive patients, fully vaccinated 53%, and not vaccinated or partially vaccinated 43%. But of those in ICU, not vaccinated at all, 54%, partially vaccinated 1%, and fully vaccinated 45%. So I'll make the point because the reality for us is, and I don't say this from my own perspective, I say it from many of our clinical teams, the reality of it is patients from less than 10% of the eligible population in terms of vaccination are taking up 43% of the COVID beds, whilst patients from 90% of the eligible population, i.e. those who've been vaccinated, taking up just 54%. And indeed, in terms of ICU, a bit more profound, patients from less than 10% of the eligible population taking up 55% of our COVID ICU beds. In fact, if you just take today's figures, unvaccinated COVID patients occupy almost 20% of our total ICU bed capacity in hospitals today. And again, I do state that not to target or anything like that. I state it because our clinical teams are asking us to state it very clearly. If you're not vaccinated, you're at higher risk. If you're not vaccinated, you're putting your family and friends at higher risk. And if you're not vaccinated, you have the strong potential to have a disproportionate impact on our health system overall. And I say that by closing on this point to say we are still there for people who want to come forward for vaccination. Very positively, we're still seeing between 1,000 and 1,500 people per day coming forward for vaccination. We are still making progress across all various elements of the community who are not being vaccinated, whether that's pregnant women, third level colleges, students, vulnerable groups, specific areas of the country with low take-up, through national and local campaigns and pop-up clinics. But I would urge everybody, it's really important for the health service to come forward for vaccination. The booster campaign, my colleague will talk about shortly, but just Damien McCallion, just to say a few points from my perspective. Progressing really well. We've been working on this for a number of weeks, and we've recently received further guidance from further elements of the population from NIAC, and Damien will outline how we're progressing and the plans against each of those. There is an early phenomenon which I'd like to flag and just say what we need to do, but certainly we are seeing a high number of appointments, people not coming forward for a high number of appointments made. And it's really important if you're offered a booster appointment that you take it up. We have seen some no-show rates in some centres varying from 25 to 50%. So it's a really important call to everybody. We are going to be dealing with significant element of the population and we need those appointments utilised. It may be just due to a sense of security among people feeling they have had 2 vaccines and don't need a booster. But we do know it's really important for people to come forward for it. And the more people receive these booster shots when they are due for you, the smaller number of people we expect we will see we are dealing with in hospitals. It's also important, and Damien will cover this as well, I just want to make the point, some of the differences between the booster campaign and the wider vaccination campaign that we obviously ran quite well throughout this year. There is an eligibility criteria, which in essence is the 5 months from your last vaccine. And as more and more groups come forward, we will be dealing with people, the groups, relative groups from the 5 month. There will always be a lag, so it's impossible to clear out everybody as groups come forward completely, because there's a lag which will tail into next year. And secondly, as all the groups come forward, we will be working through the various groups and the various age groups methodically the way we did in the last vaccination campaign. I'm going to leave there and pass across to my colleague, Anne O'Connor.
Good afternoon, everyone. I'm going to talk through the position across our services. So just when we talk about services, it's important to look at the range of services that we provide, because we often focus on unscheduled care just in a hospital setting, etc. But when we look at the breadth of services in the HSE, you can see that there's a range of acute hospital services there, scheduled, unscheduled, But we have a lot of other things, and we know about testing and tracing, etc. But public health, home care, mental health, disability, older persons, vaccination, and our community services, which is a grand title for a whole range of other services in our community health organisations, therapies, kind of child health, etc., etc. So we have a lot of different services, and the reason I'm putting this up is to say that they are all impacted when we have a surge in our COVID numbers within services. And what that looks like is that as the COVID goes up, so in terms of the highest priority, when we are really dealing with high numbers of COVID cases and high numbers of unscheduled care, also rolling out the vaccination and booster programme with, I suppose, pressures on critical care, we also have to maintain a certain amount of capacity around our flu vaccination programme, testing and tracing. And what that means on the right-hand side there is that there's a reduced service delivery in other areas. So it impacts on our ability to deliver scheduled care, home care, mental health, disability, older persons, and that range of community services that I mentioned. So our service delivery across the board starts to go down as we focus more and more on those priority COVID pathways that we have to maintain and indeed increase now. Paul referenced the plan in terms of the challenges dealing with acute hospitals or the pressures in acute sites. And we can see that really what that leads us to is a significant reduction in non-emergency services, so our non-unscheduled care, so i.e. the scheduled care provided across our acute sites, and really trying to divert people through alternative pathways. And we are seeing that now in terms of, supporting people to stay at home, working through community-based pathways, hospital avoidance measures, etc. And we will see, and we are starting to see, reduced capacity across some of those other services in terms of the need now for staff to be working in the COVID areas and supporting that very significant pressure that's there in terms of our unscheduled care, COVID, and indeed in the community services, particularly in respect of some of our home support services where we are very challenged. So the priority in terms of resource allocation goes towards the essential services that we have to maintain. In terms of the winter plan that Paul referenced, we have our plan that was published on Monday, and at a high level it is on the HSE website for anybody who wants to read the detail of it, but it sets out a plan related to 77 million allocation, and really what that is I suppose, an allocation at the beginning of the year in particular. So we are going to continue the work that we'd set out in our service plan for 2021, delivering those initiatives. In Q1 of next year, there's an additional allocation to keep a number of those going, also to ensure that we have full year costs. So we're also now trying to finalise our national service plan for 2022, but we're gone past the stage. Some of you may remember we used to stand initiatives up for a few months and then try and close beds and do all sorts of things as part of our winter plan. We don't do that anymore because we know that once we bring in that capacity, for most cases, we need to keep those resources in place, keep those beds open, etc. So we are continuing, as ever this winter, to focus on hospital avoidance and egress pathways for people who are being discharged from hospital. And we have those set across 5 key pathways: building capacity, the pathways of care, testing and contact tracing, population health, and that's population health in its broadest term, i.e. keeping the health of the nation, I suppose keeping people healthy, flu vaccination, etc., and overall then vaccination in terms of the COVID vaccination as well. The key allocations within that, there's some big chunks within the 77 million. So we have 20 million there in terms of continuing to support private capacity. That has been proven to be hugely beneficial to us as a system in terms of keeping those safety net agreements in place. And we are now looking at that in terms of continuing the arrangement from January next year. So significant funding there. Also, as Paul said, supporting GPs, so a further 10 million there. And this is really to support GPs in terms of the pressures that they experience. We did this last year too in terms of acknowledging some of the very significant pressures that are out there in practices and working with GPs in terms of additional supports, and another 20 million there in terms of continuing an enhanced level of transitional care funding. So we have already got I think 30 million in our base budget for transitional care, but what we have seen in the last year in particular is a very significant uptake of transitional care that we want to be able to maintain into 2022, because this is a key pathway for us in terms of supporting discharge for people who are well enough to leave an acute hospital but possibly not well enough to go home, or indeed awaiting a bed in a nursing home, or awaiting adaptations and alterations to houses, etc. So they're the big chunks within it. But outside of that, we have other very important initiatives in terms of additional acute bed capacity, in terms of additional community beds. And again, we're seeing a heightened demand for some of our step down and rehab beds within community settings, and the Pathfinder initiative, which has been really very, very, I suppose, positive in terms of outcomes. We have different versions of that. So one in Beaumont Hospital, which is the original Pathfinder, where we have members of the multidisciplinary team going out with paramedics to people in their homes. We have a similar, so the Edith programme, the ED in the home, it's in Vincent's Hospital, and we have a version of that in Cork, between NAS and in Cork, it's with some of our medical staff. So different versions, which are all about keeping people away from the hospital by going out and actually addressing an issue in the home to avoid them coming in. GP diagnostics, Paul mentioned, in terms of continuing that and increasing it. And as I said, private community beds as well as the public community beds there. So a whole range of initiatives that are set out in the plan. Would also draw your attention just to a couple of the other areas that are not the mainstream ones, if you like, that we are investing in. So in our from mental health perspective, having additional liaison capacity within our emergency departments for people who present, and also then in terms of our disability services, having extra capacity around supporting people to leave hospital who have complex needs in respect of disability. So they are other areas that we are trying to focus on, because we can see from our hospitals that they are also areas where we have potentially underinvested over time, and we want to improve on that. When we look at cancellations and the impact of COVID-19 on our services, this is just an example in terms of our community therapy services. And you can see there on the left-hand side of each of those, that is the 2020 number. So we can see there last year in terms of the therapy cases overall, and this is all the numbers really in terms of those areas. Last year, 122,000 or 112,000 even in January of 2020. Obviously in 21, because we were in the middle of our third surge, that came down significantly to 77,000. By the time we got to April, we were restoring services, opening services back up, and our number in 21 exceeded the 2020 numbers. So we were back into service restoration, etc., back up to 92,000. Move on to September, and we can see that the number for 21 came down again, lower than 2020, because we were recovering from the impact of the cyber attack. And again, significant catch up there. So in January, it was minus 31% in this year. We were at plus 92% by April, back down minus 18% in September. And the way we are viewing December now, which is next month based on activity, and if we were to look at a partial pandemic impact versus last year, we can see that we'll possibly be down to minus 53%. So we are seeing, based on the numbers now and the modelling that we have available to us, that there could be significant impact on our community therapy services. And again, that is as much about people being able to attend for appointments as the availability of staff and the deployment of staff to priority areas. So if we look at the need to absolutely support people to stay at home and to support hospital discharge, etc., these therapists are really important to us for that. When we look at the acute hospital piece then in terms of our Model 4 sites, and again, our Model 4 hospitals are the big hospitals that would have lots of specialties and a lot of elective inpatient care. So a typical Model 4 site would have around 100 elective inpatient cases per day, and that would include chemotherapy. If we were to cancel elective activity in any of those sites, and that would be excluding cancer and urgent time-dependent work, which we always tried to keep going even last year in the surges, we would see about a 65% reduction in activity. So that's very significant and important to remember that when we talk about cases, there's a person behind every one of those cases. And we all know people who are awaiting procedures, who have been cancelled potentially, or just have been waiting a very long time and not received an appointment. Important too to note that the cancellation number isn't always the best number to look for, because what happens in an acute hospital is, as it becomes busier and as the pressure comes on, people just aren't booked in. So they're not booked for their procedure. So it's not a case of cancellations, it's just a case of people not receiving their appointments and having to wait even longer. We are working, as I said, with the private hospitals, and we are actively implementing that safety net agreement with an average of 1,200 bed days per week being used in private hospitals at this time. And we will continue to use that and indeed increase it over the coming weeks and months. In terms of just our attendances, we can see that attendances continue to run higher than 2019 or 2020. Our admissions also just sitting slightly above 2019 and significantly above 2020. What that looks like in terms of the weeks, so just up slightly on last week, 1.4%, but up 23.5% on the same week last year, and up 3% on the same week in 2019. In terms of admissions, just down very slightly, 0.1%, but up 14.7% on the same week last year and 1% on the same week in 2019. Just in terms of our over 75 age group, we can see that that came down below the 2019 levels, having run higher than it for many weeks. And our admissions equally have come down a bit in the week. We are seeing, as the sites have become busier, it's interesting to see how the alternative pathways kick in more and more in terms of people being supported to stay away from hospitals. So actually this data could potentially look more favourable, even though in fact the situation could be worse in terms of COVID numbers, etc. So in terms of our over 75s, down 4.2% on last week, but up over 14% on the same week last year, and down 4% on the same week in 2019. In terms of our admissions, we can see that that's down nearly 8% on last week, but up nearly 10% on the same week last year. So in terms of just week by week, that won't tell us a whole lot, but we have to put that in the context of the busyness of our whole system and the fact, as I said, that we are really building on those other pathways with this investment in the winter plan, with the funding we got in NSP 2021. We're also developing these pathways, and they're kicking in now in terms of some of those alternative integrated care pathways that we've been seeking to put in place. Patient experience time, very similar to last week, at 0.3% improvement for the 24-hour PET time. For the 9-hour patient experience time for over 75s, we can see that that's up 2.1% on last week. So again, that's a very important metric because we know that trolleys will be a feature of our health system. The important thing for us is to ensure that we are adhering to enhanced infection prevention and control measures, and also looking at the length of time that people are on trolleys when they are deemed to require admission to hospital. Our trolley counts are 203 people on trolleys at 8 o'clock this morning. And whilst that's higher than the same day last year, we can see that it's significantly lower than the same day in 2019, so down 39%. And over the past 7 days, we can see the average number of trolleys is up 81% in the same week last year, but down 32%. So again, sitting in the middle there, and very significant focus on improving our trolley situation in light of the increased COVID numbers. Delayed transfers of care staying around the 500, so slightly above it, up 3% on the same week last year, or on last week even. And again, continued focus, because when we talk about the ICU capacity within our acute hospitals, every bed counts. So it really is about trying to move people through our system and ultimately to community facilities or home where possible. We've talked about the COVID numbers in terms of 643 people in hospital today with COVID. And we can see in terms of the number of admissions in the last 24 hours, that was 56, so down from 64 the previous 24 hours. But we can see that is just heading upwards, that line. And again, our daily confirmed COVID admissions over the past 2 weeks. So we can see, again, the graph going up, down slightly from last week, or yesterday. And then our ICU admissions also on the rise. And Paul has covered a lot of this. Also interesting to see this graph here, which is our non-invasive ventilation, so high flow oxygen. This for people who are not in our ICUs. But again, we can see that graph. So that is an indicator of how acutely unwell people are. And again, that graph is really climbing up there, you can see. And if you look at the left-hand side of the graph, that brings us back to the beginning of the year, where we really were at very high numbers, but unfortunately it's heading back up in that direction. Again, that puts significant pressure on our hospitals in terms of the level of acuity, and indeed the demand on our services in terms of staff being able to care for these patients outside of ICUs. Interestingly, our ambulance activity, when you look at the graph there on the right-hand side, you can see that that red line continues to run at a very high level and much higher than the projections. So the conveyances of people to emergency departments by ambulance continues to be very, very high and way over and above what we would have expected, or indeed what we have seen last year. So that is, again, something of concern to us, because these are all people who present, and many of whom require admission to hospital. So our National Ambulance Service continues to be very, very busy, and it's often for us a key indicator of how busy our whole unscheduled care system is. So just in conclusion, in terms of the increased pressures in our health system, again, a few key messages for people. So important to follow the COVID-19 guidelines, get vaccinated, and Paul has mentioned that in terms of just ensuring that people avail of vaccination and the boosters. Ensuring that people get tested and traced in line with the guidelines, availing of the flu vaccination. So again, we haven't seen a significant number of flu cases here, but the reality is, if we do, our system will be under extreme pressure. So we would urge everybody who's eligible for flu vaccination to please get it. and again, to ensure that we all do whatever we can to keep ourselves well. That's the most important defence in terms of minding our own health and ensuring that we actually don't need to attend these services if at all possible. And as Paul said, to remember the other pathways that are there in terms of GPs, pharmacies, minor injury units outside of the ED departments. Thank you very much.
Yeah, thank you. I just want to go through some of the trends here now that we're facing. So our 14-day incidence now at 1211, it peaked at 1492 in January. You can see a dip there in between. And that 5-day moving average, the number of cases we're seeing, again, a peak of almost 7,000 on the 10th of January per day, over a 5-day moving average, and now at 4211, increasing quite steeply in recent weeks. Our hospital admissions, though, have that weakened link between cases and harm is evident in that the admissions are not as high as they were in January, when we reached almost 2,000 admissions, now over 600. Our ICU admissions are 119, and just to re-emphasise that point, that in addition to this, we found that in January we were delivering enhanced respiratory support to people. That means high flow oxygen, or people on what's called non-invasive ventilation, where there's a tightened mask with high pressurized oxygen being delivered to them, and it's a resource intensive and distressing form of care. And we see now that form of care being delivered to 319 people outside intensive care settings. In any normal environment during the winter, we might see numbers of patients deliver this kind of care, but not at this kind of numbers. And 179 of them don't have COVID, but 140 do. So we're seeing lots of patients with COVID in hospital, many of them receiving intensive care, and many of them receiving enhanced form of care, which not in intensive care units, but outside on the wards. So the trends, new cases of COVID are rising steeply from September. That top graph, the middle graph, again, the hospitalisation rising from that low of 311 at the beginning of September, and the bottom graph showing the rise in ICU from the low of 552 in September to 119 now, showing that rise in cases followed by the rise in hospitalisation and slightly lag before there's a rise in intensive carers. And of course, the lag works the other way. When we do reach this peak of cases and it begins to fall, it will be some time before the illness and it goes through our hospital system before all those people hopefully get better after a long length of stay that can be upwards of several weeks in some cases, and certainly in ITU can be quite protracted in some cases. So where are we in relation to Europe? We see a high disease incidence in Eastern Europe, particularly in unvaccinated countries. We ourselves just about 7th from the top, but this graph doesn't reflect the link with harm, which is a high degree of differential across Europe, bring a much greater level of hospitalisation and intensive care pressures well and above ours even in Eastern Europe and countries with low vaccination uptake. And the ECDC has upgraded its level of concern to high, using those indicators they use of case notification rate, which is rising in many, many countries, a weekly hospital admission rate, again rising in a lot of countries, weekly ICU as well, and 14-day death rate rising in many countries. And that has gone from medium level of concern to high in the past week. Where are cases where we know that predominantly the cases are shifted to a younger population? We see much fewer cases in older population, perhaps because of the effect of the booster, the additional protection of boosters giving particularly older age groups. And we see this shift away from cases towards the left, towards younger age groups. Majority, 51% of cases in the last 2 weeks are under 35 years of age. Many of them mildly symptomatic, thankfully, and not requiring intensive hospitalisation or intensive care. But when you look at hospitalizations in ICU, the story is different. 45% almost of hospitalizations in the last 2 weeks over 65 years of age. So the harm is shifted to the right in terms of age groups and to those who are most vulnerable. Outbreaks in the past week, we see the pattern of outbreaks has changed since January, in that we see fewer outbreaks, often fewer cases associated with the outbreaks, and less severe illness associated with outbreaks, but nevertheless always a concern in vulnerable settings such as nursing homes, community hospitals and acute hospitals. But nothing like the scenes we saw before we had a vaccination program, particularly when one considers the number of hospitals that were under serious trouble in January through multiple outbreaks in one hospital setting. And again, with nursing homes, where we saw 7, 8 outbreaks a day associated with lots of cases, lots of illness, and sadly, much death. Vaccination, we remain, it's a very strong measure in this country, high degree of uptake, which is really reassuring. We're at the top in the EU for full vaccinations of the adult population age 18 or more of 93%. And looking across the age groups, high uptake right across, even where the relative the risk of the illness is relatively low in younger age groups, particularly teenage groups. We still see extraordinarily high levels compared to other countries. So we've referred to the ICU coverage here. So this we continuously look back at admissions to ICU and look at their experience, and this is continuously upgraded. So this reflects our experience in ICU from the 1st of April to the 16th of November. And this is it's not a homogeneous group of people, because as this time passed, more and more people were vaccinated, more people became completely vaccinated, and we're 14 days after that second dose. So you can see that 63% over this whole time period occurred in an unvaccinated population of admissions to ICU, and 31% occurred in people who were wholly vaccinated. So they're what we call breakthrough infections. But looking at those breakthrough infections, that's the 183, the great majority of those had an underlying condition. So it shows still, even in the post-vaccination world, that the high end of harm and the high end of vulnerability lies with people, older people, and those with underlying conditions that renders them more vulnerable to serious illness. Similarly, looking at deaths, we see 73% of deaths in those who are fully vaccinated were in the over 75s, but the majority of deaths were just in the vaccination group of 51%. But nevertheless, again, we see that differential in age and vulnerability. These are other measurements. We were continuously looking at activity of hospital-acquired COVID. That graph on the left, look at that big spike in January when lots of people were acquiring COVID in hospitals. So it wasn't just people coming in sick, widespread community transmission, but those people were coming into hospital. And despite all the efforts of our teams then, there was more COVID being acquired in hospitals, kind of secondary outbreaks beyond what was happening in the community. And the biggest single driver at that time was community transmission. But the effective vaccination, the effective infection prevention control measures, and of course the hard work of our healthcare teams has kept that, it hasn't completely negated that risk, but it has certainly kept it at a very low level. Similarly, outbreaks, they're rising, but nothing like the levels we see broken down by hospital group on the left-hand side. On the right-hand side, that graph shows the number of confirmed cases in acute hospital staff. It has risen in recent weeks, but not nearly to the level it was in January, when again, despite all those PPE and all those other measures we had in place, the widespread community transmission found its way, seeped its way into the hospital, and it resulted in hospital-acquired COVID and in acute healthcare workers becoming positive. Similarly, with outbreaks, these are different surges. On the right-hand side, you see the outbreaks in community hospitals, nursing homes, and COVID-19 broken down by community hospital in dark purple and nursing home in pink, and you see still a lower impact, not just in terms of number of outbreaks, but the number of cases associated and the seriousness associated with those outbreaks. So what are other countries doing? We see a whole range of measures. As Hans Kluge said, that Europe is now the epicenter. He attributed this surge in cases to low uptake of vaccines and to a relaxing of social measures and adherence to public health measures. So different countries have brought in new rules. In Latvia, some stringent rules, such as permission to dismiss employees who refuse to get vaccinated. In Netherlands, a curfew for retailers and some reimposition of social distancing measures. And Austria, a focus on those who are not vaccinated. So just turning briefly to the booster, and I just want to emphasize through these couple of slides before I finish, is the impact of the booster. We have made huge progress with boosters already. We see a steadying of incidence rates in older people. And what I'll show you now is what we need to do is encourage as much uptake as possible to protect people against infection. We're not operating from the baseline of January because people have protection from their existing vaccination regime. What the booster will do will give additional protection going into the winter months. So this came from Public Health England. Vaccine effectiveness against severe outcomes such as hospital admission remained high for months after that first course, but began to wane, especially in older adults. And 2 weeks after receiving a booster dose in adults aged 50 or more, the protection against symptomatic infection was 93% those who originally got AstraZeneca and 94% who originally got Pfizer. So good protection against symptomatic illness from the booster for those aged over 50. The Israel study in Israel have always been ahead of the rest of the world in terms of rolling out the vaccine and now the boosting vaccine. And look at that big reduction. That blue line in both graphs represents the reduction in hospitalization and reduction in severe COVID after a booster regime. So the booster regime gave a big reduction in hospital admission and severe illness in Israel when it began its booster campaign. From the United States, that left-hand side shows the falling effectiveness of vaccination against symptomatic infection. On the right-hand side, it's the severe harm as manifest by hospital admission. The vaccine seems to, the protection it affords individuals from more serious end of spectrum of illness seems to be more sustained than the protection against symptomatic infection as a whole. And finally, from Israel, look at that black dotted line in the middle is when the booster regime began, and you can see a fall in the top of cases, the middle of hospitalizations, and the bottom of deaths. So it does appear to work, and in terms of impact in other countries. You've heard all about the modelling, a vast range in terms of impact on cases, hospitalization, ICU, from pessimistic to optimistic. We are not helpless bystanders here. It's not as if we're watching this play out in front of us. We all can and should play our part in making sure that it's that at the very least that we're verging towards that optimistic model, which will save lives, prevent cases, prevent huge distress, and relieve our healthcare system. So finally, the key messages: our whole healthcare system is significantly stretched due to the number of cases and the illness associated. Our intensive care units are under considerable pressure, and there's an increasing need for supportive intensive type of care outside intensive settings. Unvaccinated people have no protection from the virus. They can pick up the virus from vaccinated people, and unvaccinated people who've recovered from COVID-19 have less protection than vaccinated people have and can still be reinfected. Vaccinations alone will not control case numbers. It's that those public health measures, particularly self-isolating with symptoms and reducing our contacts, remain critical to control case numbers. Vaccination remains protective in reducing serious illness, but waning immunity necessitates a booster campaign for specific groups to give them additional protection going into the winter. Finally, the prevention of illness requiring intensive care is much easier than treating someone once they need intensive care. I'll now pass you over to Damien McCallion. Thank you.
Thanks, Colin. So I'll just start with some of the key messages from testing and tracing. So as people know, we've seen a very sustained high demand, as Paul and Anne and others have referred to, in terms of our community testing centres over the recent weeks. They were initially established to support delivery of around 15,000 tests a day. We then set up surge capacity to go to 20,000 a day. And on some days in recent weeks, we've been exceeding that on 6 of 7 days and hitting numbers like 25,000. So clearly there is some strain in the system in relation to that. Having said that, our priority groups are around GPs and close contacts. And in general terms, we're getting those through in terms of the following day. In recent days, it has been busy around the country, and there are some areas from day to day which will vary. But maybe just to illustrate the variation in that, Donegal, as people may know, in Ishowen, had very high numbers as recently as 6 to 8 weeks ago. Yesterday afternoon, there were 475 appointments available in Letterkenny, whereas in other parts of the country, clearly, we didn't have the same number of appointments available. So it's just to reflect there are geographical issues there that we're trying to work through in terms of how we develop the model. And Paul referred to 1 or 2 points that I'll come on to in terms of improving the service and trying to increase the capacity. So the sort of areas that we're looking at is we have partnered with some private entities, and we've opened a new site in Dublin, which was under pressure, with over 1,000 bookings a day now available. That commenced on Monday, and it's working very well, and we're planning to extend that even further. We'll have additional sites in Limerick and Cork opening next week, and we're also working with a number of other agencies who we can help develop some more capacity. Separately as well, we're looking at additional resourcing. We've had ongoing recruitment campaigns running, and we're continuing to do those. And I'll come back to the general resourcing challenge that Paul referred to later. The last thing I would say is if someone is looking to get a test, in general in many parts of the country on a day, you will be able to get a test. If you cannot get a test as a self-referral, it is really important. The crucial thing, and the CMO referred to this yesterday, is that you follow the public health guidance if you've got symptoms, which is to restrict your movements and to isolate. So it's really important, even if people have a slight delay to get the test, that they follow the core public health instructions. That's ultimately what this is about. So just some of the indicators that we can see, again, these have been referred to, huge number of laboratory tests. We've built up capacity. I can recall last year when we thought 100,000 was an enormous number in terms of PCR capacity in this country, and we're generating numbers now close to 200,000. So those are huge numbers every week. We've built a system that's designed to do huge scale very, very quickly. Let's flick back there. And that has functioned generally very well. So there certainly are some strains at the moment, and we're working to try and improve those through the various measures that I mentioned earlier. The other measure that we're doing is we have what are called mobile testing teams, and that allows us a little bit of flexibility when we get strains in different parts of the country where there's demand perhaps in some counties that wasn't there previously. We have 4 of those teams at the moment, and we're going to extend those teams over the coming weeks and right through the winter period to try and ensure that we can respond, I suppose, to any geographical variations that I referred to earlier. Broadly speaking, in terms of the priority groups, GP and close contacts, we're getting to those within 24 hours. Some self-referrals may have to wait longer, again, depending on any day. And I would also flag, and it's probably an important message for the public, because we hold back slots for general practice, it can often happen during the day that slots reappear, and every night at midnight then we open the 2 days forward in terms of the following day. So there is always opportunities, I suppose, even if people I know sometimes see 0, those slots can become available later in the day for people as well. So just moving on to our vaccination programme, column has again reflected just the high numbers that we've had in terms of the primary doses and our rating in Europe in that regard. And that's important to remember, I suppose, when we look at the booster programme. It's really important we apply the lessons that worked well to the booster programme, and I'll come on to those. Just in terms of the uptake and the slides that both Colm and Anne referred to in relation to the impact, and Paul, on the percentages of unvaccinated people in ICU and so on, while the number may be small and we may have the highest rate in Europe, we're continuing to try and focus on areas where we feel we can still get people vaccinated. So just to illustrate the point, in the general population, over 4,500 people over recent days, again, continuing to get their first dose. And on some days, we're getting that up to 1,500 people. So we're still encouraging people to come forward. And some of those people are very elderly. In recent weeks, we've had people in their 90s coming forward for their vaccine for all sorts of reasons. So irrespective of your age, irrespective of your background, we would encourage you still to come forward. You can both help your own health in terms of preventing serious illness and ending up in ICU, and also in terms of your family and the wider population. Good progress made around the pregnant groups and people who are pregnant, in relation to 58% of women now confirming their vaccination status and 75% of their partners. And they were much lower before the good work done by our clinical teams in relation to trying to get those groups up in terms of the uptake and increase the numbers. A lot of focus on counties where there were slightly lower uptakes, but not just the county. We looked at what are called local electoral areas. We've used pharmacies, 45 pharmacies identified within those electoral areas, and we've had 11 pop-up clinics where people could be vaccinated with easier access perhaps, and just to encourage people to come forward in some of those areas. And that's worked fairly well in terms of the numbers I mentioned earlier, about the 4,500, for example. Working with industry, healthcare workers in terms of trying to address any vaccine hesitancy across all sectors. And again, in terms of our walk-in and pop-ups, there's some figures there in relation to the success of that. Lastly, around the migrant communities, also trying to develop further the materials we have, promote those. We've always had a wide range of materials through the good work of our communication teams, but trying to promote those more widely, working with various embassies, different groups, migrant groups, working with employers who would have a large number of migrant communities, working with them to try and encourage that uptake. So moving on to the last part of our primary dose, it's important to flag that the immunocompromised is a third dose. These people will also be entitled to a booster at a later date. Population estimated to be around 75 to 100,000, identified through our hospital system and general practice. Around 92,000 people identified at this stage, so coming close to full identification. 61,500 doses administered. And just to flag, in the CVCs or vaccination centres, we are finding it is taking a lot of appointments to get people through. And clearly, what we would say is we would encourage people to come forward as quickly as possible, particularly this group, because this will give you extra immunity and extra protection. So really important. Just broadly down on the booster programmes, taking the areas, the over 65s in long-term residential care, substantially completed. Following the recent NIAC advice, we will now be in a position in the coming weeks to go back and vaccinate all the younger people that are in those facilities, and that's welcome. But in terms of the over 65s, that's substantially done. There will be some facilities we have to return to where there are people perhaps who had COVID or were ill on the first visit, and those are now being done. Those visits are continuing. In terms of the over 80s, been done through general practice, a lot of good progress, and we believe that's still on track to complete in the coming week or so. And again, although there's a small number there, the feedback from GPs is very positive in terms of uptake for that elderly group. So that's really positive as one of the most at-risk groups from the whole service here. 70-79s, again, big population, 336,000. Good progress through general practice, again, in terms of 130,500 vaccinated. And most of those people that are eligible will have their appointment or be vaccinated by the end of November. And the really important point that was referred to earlier, the initial advice was recommended at 6 months with an ability to have a minimum period of 5 months. And now, following clarification, we are now able to call people at 5 months, and we'll be transitioning to that over the next week or 10 days in terms of the appointments. But again, people will be called in the main as we work through the groups, and they're eligible as we work through all of these different population groups and other groups. 60-69s just commenced. Again, there were a small number eligible initially, small numbers done, and that will start to ramp up over the coming weeks with bigger numbers becoming eligible as we work through it. But just to flag what's really important, many of these groups will run right through till next March based on eligibility. So there will be a rump, there will be large numbers that need to be done in the coming weeks, but many of those then will still have people who will still be eligible and need their booster right through till next March. On the housebound, just to flag, again, this is a really important service. It may be a very small number of people, but crucial for people who are at home who can't get in to get a vaccine from a GP or from a vaccination centre or from a pharmacy. We've been working that programme through for the over 80s, and we're now extending that down to the over 60s in line with the guidance, and we'll extend it further as needs be as we work through it. Lastly, then, our healthcare workers commenced just over the 6th to 7th of November, just over a week ago, over 100,000 already administered. And the majority of those, again, there will be some people who will still run into next year, but our target is to have those offered an appointment or vaccinated by the end of December. So just really in summarising that in terms of the booster programme, one of the key things we learned last time is to try and work through the groups in a methodical way as possible. The complication with the booster programme, unlike the original programme, is people had no immunity. There was no other barriers in terms of eligibility or other factors that we had to consider. So it was a much easier process once we moved to the age groups. We will have to factor in the eligibility as we work through these groups, and we will do that as we move forward to their eligible date. But people shouldn't be concerned. As we work through the groups, it will take time to work through some of those groups, and we'll be clear in terms of the approximate timelines for dealing with the substantial numbers, bearing in mind that every group will run from, if it commences in November, it will have to continue, say, till next March in relation to some of the people. So to illustrate the point, a healthcare worker who's just vaccinated in the last month, new person, they will have to wait that 5 months to get their vaccine at a later date. So there will always be some of that, but we will work through in a structured way. We learned from what happened and what worked first time round, and we'll attempt to repeat that this time round and ensure the communications around that are strong. Thank you.
Fergal.
Fergal Bars, RTE News. Can I ask you, Paul Reid, first, what's the potential impact of the that 5-day rule on if you're a close contact of a household member who's tested positive? What's the impact of that potentially on HSE staff and services? You might say how many people are out at the moment because of COVID-19, but then this could have, I presume, a significant impact potentially.
Yeah, and thanks, Fergal. And it would have, and we would be very concerned about that. We're working through right now in terms of how a derogation would apply to healthcare workers who would have to, first of all, if their household get the 3 tests, but they would be able to go to work under certain monitored conditions at work, as we had to do in the first phase. So derogation would apply to the extent that they but would continue to restrict their movements to the best they can, but they can go to work under certain monitored conditions like temperature checks, etc., and take the 3 antigen tests as per would be recommended for the wider population. But yes, that would have had a significant impact on our resourcing, and that's the way it would apply. Colin, do you want to add to that? Is that okay?
Yeah, exactly. This happened in the first phase, and given the huge dependency on our services at this at their state of current fragility, we're finalising our derogation document along those lines, recognising, of course, that the risk is much lower because the healthcare workers are vaccinated. So.
Just to say, as of the last count, that was last week, so we do it every second week. So we expect that to go up next week.
Never covers people who are symptomatic or have positive tests.
Damien McCallion, just in relation to the boosters. So what you're saying really is that, I mean, quite a large number of people will be waiting until certainly March next year before they get their boosters, depending on eligibility when they got their their second jab. So the booster campaign will certainly go up to next March. Does that include the very latest recommendations in terms of those aged 50 to 59 and people younger with underlying conditions? Are we still talking maybe March or even longer into next year?
So I suppose the 5 months, Fergal, sort of dictates nearly the duration of the booster programme, in the sense if someone's vaccinated today, they'll be entitled to a booster in 5 months' time. So there will be, I suppose, a large number initially over the coming months, and then there'll be smaller numbers from there in terms of the programme. We're just assessing the recent guidance in relation to the medically vulnerable and the over 50s, and we'll incorporate those in. But again, based on when they were vaccinated, we still believe a lion's share of those will be done over the coming months, and then there will be what we call, I suppose, a tail to that in relation to numbers that will shrink as we move through the months. But clearly, if someone's vaccinated, those 4,500 that are vaccinated in recent days, for example, once they have their dose 2s, they'll still have to wait that minimum period of 5 months for their booster. So we will be continuing. In some ways, it may have some parallels with the primary programme, where we tried to get through the substantial majority and then focus in, I suppose, on trying to deal with and catch with people who were, hadn't been vaccinated towards the end.
It is a message we're trying to help all of us, public in particular, understand. As your age group, for example, is, like the 50s you just described, recommended by NIAC, it's not just your age group, it's the point of eligibility. So that 5 month thing is really important for people to understand, and we will be calling and moving through based on eligibility criteria and working on that basis.
And Paul Reid, can I ask you, would you characterise the, I suppose, the notice that you sent to the level 4, the larger hospitals, where we'll see a significant curtailment in elective procedures, as close to or in effect comparable with the directive in January of this year to pretty much cease all planned operations and procedures?
Yeah, I think, and just in terms of that letter that we issued out, that was a two-way engagement with the system. So, and each site will make their judgments based on that. But we are, number one, supporting their decision-making in that process, and clearly expecting that they would work through to protect and reduce the mitigations that those decisions would have to be made. Is it exactly the same as, say, in the first wave and indeed in the wave from January to February? We're not giving the national direction out to cease everything, but we are supporting and giving them the mandate and expecting that they would do it to reduce the risks, and particularly on our level 4 hospitals. And Anne and Colin might want to comment on that too.
So I think the important thing is, as Paul said, there's a nuance in there for sites that can manage. They don't have to cancel things. The last time it was everything stopped. And the other important point is that our Model 3 hospitals are hugely important to us in terms of patient flow. This relates to the Model 4 hospitals at this time, but equally it stresses the need for, I suppose, an integrated response across the whole system, because actually the community services are also key for us here in terms of prioritising the support to keep those sites with patients flowing through and that. So it's different in that way.
Hi, Roland Smith from the Irish Daily Mail. And just a quick question. Do we have any numbers about cases actually in schools at the moment? I know we stopped doing serial testing, but I was just wondering if you had any information on that.
We have a relatively small number of outbreaks reported in schools. Based on the work of our public health teams, the great majority of children who acquire this, because of our opinion is based on the trajectory of cases and the rise in different age groups, the great majority of cases are acquired in household settings, especially since increased social mixing and release of social restrictions. So schools are relatively controlled settings, and through the work of the school teams there, principals, teachers, parents and everyone else, we've managed through the establishment of pods and through the other measures that schools have done to try and keep risk as low as possible. And the opinion of our public health teams is that the rise in cases we've seen in children, as in all age groups, came after the rise in older age groups, which drove the community transmission and led to children. That isn't to say that cases don't rise at school and aren't acquired at school. Of course, that can happen.
Cayman Burke, the Journal. There's a lot of frustration regarding testing. We're just wondering what has been done in the very short term, like the next 48 hours, to ramp up the testing, PCR testing.
I just say a couple of points on it. Look at the level we are at. We're at one of the highest capacity levels in comparison to many other European countries. If you remember the debate at the start of this COVID, can we get to 100,000? When will we get to it? We scales and surged up to that. 198,000 lab tests in the last 7 days. So this is a phenomenal rate we are at. And it is because the virus is so rampant now in the communities. So we will be saying to people, you can get slots and keep looking at it, and particularly symptomatic and prioritisation through GPs. But there have been occasions, and there may be occasions, where you may have to wait. And if you have to wait and you are symptomatic, it's really important you stay at home. But the delays have been minimal in terms of the scale that we have stepped up. There is a point at which you can step up this capacity any further, of which it adds certain value into the system. But we've done that. We've doubled our capacity from 100,000 to 200,000 throughout this COVID.
Given the cases are likely to stay high for perhaps quite a while, why is it that the HSE is outsourcing to private companies as opposed to ramping up this capacity itself?
A combination of scaling up completely within the HSE resources, so our lab capacity, our swabbing capacity, our swabbing centres all across the country. I mentioned in my early presentation, we have a resourcing demand that we've never seen anything like it before, from a hospital system, from our community system to resource up swabbing activity. We do have to go where we can get further activity right now, and that is a minimal activity where we've been able to secure in private capacity. So we're doing both. Damien, you might please feel free to add.
I think Paul has summed it up well. I think in terms of whether it's public or private, and there is a limit that you can go to. You can just see that where do you start to drop, set a bar. But effectively, all the measures I outlined will help to support the capacity to another level. But that's in the context of a health system that's got demand for resources right across the board. So that's why we're exploring all possible options, both expanding the current workforce, but also private options in relation to people who perhaps can assist in the current demands. And you talked about the next 48 hours. The solution in Dublin Airport was put in place in days, just to illustrate, I suppose, the flexibility that some of the teams that are involved in this have, on top of all of the ongoing processes, recruitment and so on that are there. So.
We do have extra centres, we have extended hours, we have pop-up centres, we have our National Ambulance Service, we have all our swabbing teams from the community. They're all in-house.
If we could just go back to the 14-day incidence rate for a sec. I believe you said we're 7th worst in the EU, but if you look at that geographically, pretty much all of them are in Eastern Europe, with the exception of Austria, which has the worst vaccination rate amongst Western European countries. So and we've seen Ireland are the best vaccination rate in the EU. So why is it that we're essentially second worst in Western Europe despite having the highest vaccination rate?
That refers to the 14 instances of COVID-19 infection. But when you look at how that links through to harm in terms of people who become hospitalised in ICU, if we had the corresponding numbers of hospitalizations in ICU, we would be utterly overwhelmed with hospitalization, people requiring hospitalizations in ICU. So what we see in countries with a much lower vaccination uptake is not just high numbers of cases, but very much higher proportionate pressure on their hospitals and ICUs, because they don't have that layer of protection that the vaccine program gave them in terms of preventing severe illness, which I highlighted later in the slide. So yes, we're seeing high levels of infection from COVID-19, but we have to distinguish that from high levels of harm. We are seeing certainly serious pressure on hospitals and ICUs now, but nothing to the level that we would have seen if it wasn't for the protection given to us by vaccinations.
Hi, Niamh Griffin from the Irish Examiner. Just on the safety net agreement with the private hospitals, how much flex is there in that, and how quickly could you expand that if the cases reach that pessimistic scenario?
Yeah, there's discussions going on right now at the minute. The safety net agreement, as we currently have it, continues to the year end, and we're also looking at a further extension of that, obviously. But it's quite flexible in its scope in terms of how we would utilise that capacity. It gives us capacity of up to 30% of private capacity. We have been using a significant proportion of that, about 1,100 bed days per week, and we do see it going up to 2,800 to 3,000. But in terms of utilisation by the hospital system, it's quite flexible, whether it's utilised for elective care, which we want to try keep going, as Anne said, where we can, or indeed urgent non-COVID care as well. So it's quite flexible in its use, and we're in discussions about a further extension.
And if it goes up to 3,000, what kind of percentage is that? How close to the 30% are you then?
We're getting quite close to 30% at that stage. Yeah.
Thank you. And Anne, you were talking there about the pressure on the community services. Like, are we already seeing speech and language therapists and people like that being redeployed into vaccination and other COVID areas?
No, we went through a lot of work last year making sure that those therapists could get back to their core roles, so we haven't deployed them out of those.
And do you think they will be needed to?
I think that it's very challenging at the minute, so community testing is under extreme pressure. So in terms of, we will do everything before we do that, put it that way. So in terms of actually working with the Defence Forces, looking at other solutions, as Damien and Paul have set out, we really want to keep those therapists there for the other work that I've mentioned in terms of just winter and supporting people at home, etc., etc. So that is our least preferred choice in terms of taking those out of their core roles.
What you're saying, obviously, and everybody is hearing about the current wave of COVID-19. But you can construct an alternative narrative from the figures you provide and that other people provide. And your graphs show that in many ways, the situation in the hospitals is not much worse than it was 2 years ago. In some ways, it's better. If you look at I'm looking at the INMO's Trolley Watch figures for today. Number of patients on trolleys or waiting for admission. Beaumont 0, Connolly 0, Naas 0, Cavan 2, etc. And then obviously you go to Limerick and it's substantial. It's 58 and quite a small hospital like Letterkenny 49. And if I looked at those figures several years ago, they'd be the same. So how can you, and I've written about this, how can you seek the confidence of the public if parts of the health service don't seem to be functioning as well as other parts? How are they supposed to get through the inevitable winter surges, whether they're caused by COVID or other respiratory or other diseases, without all parts of their health service firing on all cylinders?
Just a few comments, Paul, on that. First of all, just complete caution on numbers and relative numbers and comparison to any stage of COVID so far. We do know, and we're saying this regularly, COVID positive patients have a highly disproportionate impact, particularly on our hospital system. So when we have now today 643 COVID positive patients and 119 in ICU, we then have to curtail other activities and other wards. We've isolation, we've closing wards that have COVID positive patients in them. So it has a highly disproportionate impact on the hospital system. The second part of your question related to comparisons between sites. Yes, there are, and some of our bigger sites have managed much better at the early stages, particularly in terms of capacity. But even if you take the likes of Beaumont was probably 2 to 3 weeks ago in a much stronger position in terms of COVID positive patients, as in they had less of them. In a 2 to 3 week period, that has transformed, and all of our Model 4 hospitals feel the strain. So it's not just a simple comparison of trolley numbers, and I'm not certain you're making it, but it's not a simple comparison of the trolley numbers, hospitalised cases and ICU. It's the impact it's having on all other elective activity and non-COVID care. And sorry.
I think, Paul, if you, so I take your point. A few years ago, if we had our delayed transfers of care at 500, we would have thought we were doing very well compared to the 700 or whatever it would have been. Remember 2019, we were heading into an early and bad flu season at this time. So the comparator to 2019, we were in a bad place in 2019. So saying that we're in or around 2019 isn't great for us this time of year when we don't even have flu. So that'll be one point. Secondly, the other thing to remember is the significant investment in community services in the last 2 years. So we've developed a whole range of pathways to support people to stay out. So all of that activity is going on now to have an impact, and it has. And we're looking after a lot of people away from hospitals that we wouldn't have done 3-4 years ago. So all of that is additional activity. And the final point is Trolleygar is a reflection of many things, but is something that absolutely reflects a scaling down of elective work. So once we start scaling down, Trolleygar will start to go green. That's the reality. So the trolleys, so the bed capacity issue is what drives the trolleys. And as soon as we stop booking people in and reducing our scheduled care, we will see an improvement on trolleys. So it's not a great metric in terms of how the system is working overall. You have to look at all the different metrics together.
Paul, could you just clarify what you were saying earlier about your discussions with the sites? Are you already talking about, was it some curtailment of service, or I heard significant curtailment mentioned?
Yeah, no, we've given, look, Paul, sorry, they've already made decisions themselves and they've started this process. What we were doing in the note that I sent today was obviously, endorsing and supporting them on that and giving a mandate for the sites where they need to do it. It's significant in some sites, and as Anne had said, some other sites are managing to keep some elective care going. But overall, we see it in the next 2 weeks as having a significant impact.
But you're not issuing any central instructions?
No, we didn't give a central instruction to stop. Our central instruction says assess the activity that you have going on. We have to prioritise COVID and non-COVID urgent care. And if you need to make decisions around elective, make them on a site-by-site basis. Colin, do you want? Yeah, there's a clinical guidance that we've given to them.
Sorry, just one thing. You talked about pregnant women, 58% or something, who confirmed their vaccination status. But how many of them are vaccinated? Is that 58% or is it some other figure?
Yeah, that's based. We did. Sorry, is that okay? Yeah. We did cross-section surveys of women based on self-reporting, and that's done in all 19 maternity units. And the 58% report that they're vaccinated, and that 74% of their partners are vaccinated. So it's based on a point of time repeated survey in all 19 units of self-reporting against those questions.
Just in the early days, Paul.
News talk. I think for a fair few people anyway, when they kind of hear about pressures in the health service, it kind of comes back to this question of, well, why haven't we just increased capacity then to deal with these pressures? So I suppose, would you be able to give a bit of an explanation as to why, say, for example, the conversation around ICU beds, it kind of keeps cropping up. So could you perhaps give an explanation as to why that capacity hasn't been increased more to deal with the kind of surges that we're facing now?
Yeah, I'll just tackle it from two perspectives, and Anne and Colin will come in on this one. So first of all, in terms of bed capacity, over the last year, we've put in almost 900 beds, certainly well over 850 beds in our acute hospital system. And certainly throughout COVID, we do know that we started from an extremely low base of ICU bed capacity and still are relative to OECD measures. But we did move it from 255 beds to just on 300. And we expect to bring some more on shortly as well. But I would say to you is, just look at all of the probably well-respected and well-funded hospital systems across Europe at the moment under severe strain because Europe is the epicenter of what's happening. So health systems like Holland having to make decisions and under pressure, Germany and other health systems under severe pressure. There is a point at which any health system gets under severe strain on this, and there's no doubt we have capacity challenges in our own health system. That's a reality that we have to manage through. So we are under pressure. We will be under pressure. The other point is, there is a point about what stops this happening, and these are obviously choices as well. Do you let the virus continue to run and more people end up in ICU and more mortality? Or do you try adopt the public health measures, which we're calling on today, and stop that flood coming through and reduce mortality and reduce ICU? So they're difficult measures.
And maybe just add to that, I think in terms of capacity, we have to stop thinking of the health system as just our hospitals. The response to a lot of this is the integrated response. So that a lot of the investment that we've seen has been in line with Launch Care in terms of the non-acute piece. So obviously investment in acutes, and as Paul said, it's about, I think, over 800 acute beds, but equally there's hundreds of community beds that have gone in, and critically significant investment in home support, community diagnostics, all of that, which is really important. So in terms of, we've got to think of the healthcare system as a pathway for people from home all the way through services into hospital if they need to go there and back home again. And I think that, when you look at the totality of that, there has been a lot of investment, a lot of capacity building, 10,500 additional staff since January of last year. That's on top of recruiting about 7,000 or 8,000 to just replace people who leave. And we do expect to see more people leaving now. So we didn't see a lot of that in the last year because people were not retiring early because they were staying with the COVID, kind of national, kind of whatever desire to help and to stay there. But equally, we didn't have people going abroad. And we expect to see more people leaving. So when we talk about capacity building, we have to look at people, we have to look at systems in terms of improving our pathways, integrated care, and we have to look at equipment and infrastructure. And the reality is, our hospitals, wherever we've been able to develop beds, we have done that. We don't have a brand new hospital that we can open, so we are developing or adding bits to hospitals. We are adding bits to our community services. We are adding bits to our mental health services. So I think, we can't say we haven't built capacity. We've actually built a lot of capacity. But the reality also is that if there are people out there, so for example, I would guess there aren't really ICU nurses in Ireland who want to work with us who aren't already employed with us. So for us to actually recruit that level of staff, when you talk about ICU beds, it's not just about plonking a bed into a corridor or into a room or wherever. It's actually about having a developed system of care with 7 or 8 nurses around each bed. So there are lots of complexities within that.
I suppose just make the point that, the almost the entire adult population is vaccinated now. So I think a lot of people would kind of be of the view that, there's not really too much more they can do. Obviously, and at the minute, it kind of just seems to be a choice between, the going in and out of kind of, severe restrictions or kind of varying restrictions of varying severity or increasing healthcare capacity. So is that not the case? I mean, a lot of people would say, look, like we can't kind of live with these restrictions indefinitely. Do we not just need to do whatever it takes in terms of that? Making sure that the health system can actually cope with this.
Can I just make a quick point and pass to Colin? Anne has outlined all of the capacity enhancing funded mechanisms that we've had from government and put in place. So I won't repeat those, but they are all key. But the second point I do just want to make, Paul, these are big issues. What more can the public do? Exactly what we have been asking this week and what the public are really good at, which is the basic public health measures. They will make a big difference. We do know, and the obvious evidence is, the immunity from the vaccine wanes over a period of time, and we will be on a booster program to address that. But what the public can do is exactly what we've asked. These public health measures make a really big difference in the coming weeks. So, Colin?
It's questions asked about expanding ICU beds, and we have expanded. We had a low base, as people know. It's a lot of work. It's not just the bed, it's the equipment and the training, as people have said. But should any healthcare system be designed where over a third of the intensive care capacity is occupied from one virus alone? It's not just a surge; it's a displacement effect. And of course, no healthcare system should be designed around the needs of just one virus. It's not a sustainable way of building healthcare, especially when there's alternative means. And yes, it's hugely frustrating for us and for people and frontline staff and for the general public that these measures are being asked of them again to prevent more cases coming into intensive care. Of course, that's true. But there is a way out of this. We're learning more about the vaccines. We learn about the sustained protection they give us from serious illness, but we're learning too that immunity wanes and that vaccine requires a booster, and that booster needs to be rolled out. And we know from other countries where that booster has been rolled out that affords significant protection against serious illness, hospitalisation and death. And that puts that isn't an extraordinary position for a virus. If you look at influenza, for example, a different type of virus nevertheless, but there's an annual vaccine program for influenza because the strain changes every year, and last year's last year's immunity will not last long enough for you to get a vaccination for what is the strain most prevalent this year and what you need this year. So there's a way out of this that ultimately will involve, at some stage, this virus becoming endemic, where we will see outbreaks, seasonal outbreaks, where we will see a vaccine program that is yet to be determined by the world, because we're only learning to know how these vaccines work in a sustainable way and what additional boosting regimes are necessary. But it is not a sustainable solution to build an extraordinary level of intensive care that would require redeployment, recruitment on a scale that would shift care completely over to one very small but necessary part of healthcare, just around the surge needs of one virus.
Sorry, just last point on that. I mean, I suppose some people might point out, and as has been said by yourselves, ICU capacity was much lower in Ireland than in other similar countries. I think it was half the OECD average in 2020. So some people might argue, even if we do have to build up the ICU capacity, it's not like it's going to be wasted. A lot of people say it should have been at that level anyway. And just the last thing on that, I suppose, what is the aim for overall ICU beds in terms of how many we're looking to eventually scale up to, and how long is it going to take us to get there?
Current funding levels from the current National Service Plan brought us from 355 to 321. Sorry, 255 to 321. And we're obviously working through the National Service Plan next year and funding and capital plans. So current funding streams brings us up immediately, but I think government set out a trajectory to bring it to over 400 by the following year. 400. Yeah.
So there's I suppose, a big capital development that's required kind of next year and beyond.
We're still working through in terms of the funding aid.
Rowan Smith from the Irish Daily Mail again. Just on the antigen testing for primary schools, I'm just wondering, is the HSE going to be collating the data of the amount of antigen tests that test positive from that?
Yeah, I can cover that. So what we've rolled out is a solution for all sectors where we capture those results online. So when people are tested, be they children, as we say, in a national school setting or any other setting, there's a mechanism where people can record those results, but not only record the results, it automatically takes them through to book a PCR test, which is the recommended public health action if you get a positive antigen. So there is a system there to track that in relation to the positive results. And we've about 70,000 results, the majority of which are positive. Some people will record negative as well, but that's the exception. So that solution's in place. It's been in place for some time, supporting the food industry and just a wider use of antigen tests.
And then just on the capacity of the testing and tracing, will there be enough capacity, say, if there is a load of positive antigen tests in schools, or even parents deciding not to even bother with the antigen test and just take their kids straight for a PCR test? Is there additional capacity to deal with that in case of a surge?
Yeah, so I suppose, we've talked about the steps and measures we've been taking to increase the capacity around the PCR testing, but also there's a limit at which you get to. So essentially, I suppose if someone's symptomatic, the advice remains the same for a child as it is for an adult. You self-isolate, you restrict your movements, and you follow the public health advice, and you will then be able to book a test through. So we're growing the capacity in general, and obviously that'll have a benefit both for the wider pressures on the testing and tracing system,